A very pleasant afternoon to all of you. We at Docplexus always aim to bring to you the latest insights in medical field so that together we can become a stronger community empowered by information and knowledge. Now I cannot begin to describe that how this pandemic has affected every single aspect of our life and changed everyone's perspective towards health and life altogether. I believe children are most susceptible to changes, both external and internal, and this pandemic has definitely impacted their lives as well. Although, in a majority of cases, disease seems to be milder in younger children, it's still important for caregivers to understand that the children can be infected with COVID virus and the corona that causes COVID-19, and it can be transmitted to others as well. In some rare cases, children can become very sick with COVID-19. That's why it's important to use precautions and prevent infection in children as well as adults. Our today's speaker is an expert in the field, and I'm glad to introduce Dr. Tanu. Hearty welcome to you, Doctor, from the entire team of Docplexus. Now, Dr. Tanu is a trained pediatrician from AIMS Medical Sciences, New Delhi, and she's also mastered in infectious diseases and international health at the London School of Hygiene and Tropical Medicine from London, UK. She acquired expertise in pediatrics and infectious disease at Hinduja Hospital, Mumbai. She is now associated with Kokilaben Hospital since its inception and is a consultant in pediatrics and infectious disease. To her credit, she has 20 books, two books, 20 chapters, 65 publications in various international and national journals. She is advisor to the ICMR on antimicrobial stewardship, technical expert in pediatric tuberculosis for the National Tuberculosis Control and Elimination Program, and she is also an executive board member of the Fungal Study Forum. We welcome you on the platform, Dr. Tanu. I would now request you to please start with the presentation.
Um, Hello everyone, and can you hear me? And is my screen visible?
Visible, you can please go ahead.
The moderator.
Yes, doctor, your screen is visible. You can please go ahead.
Okay. Today, I would be talking about the third wave of COVID as well as children. And, this is something which is just of the newspaper today, where, the AIMS director, that is Dr. Randeep Guleria, said that we are going to have an early third wave because you can well see from this picture that there is a lot of crowding happening in the country. In fact, a few days ago, we had this statement from Maharashtra COVID-19 task force, which said that it could hit us as early as in 2 to 4 weeks. So, and apart from that, there is also this thing going around that if there is a COVID-19 third wave, then children have to be really protected and all our efforts have to be geared towards protecting them. So, as we are nearing to a close of the second wave, the media and scientific literature is awash with a discussion of a third wave. Also, it is being speculated that children will be preferentially affected in this third wave. So the questions in our mind are that will a third wave happen? If yes, when is it going to happen? What will be the severity? And will children be selectively infected? So we will ruminate on these questions with the understanding that there are no accurate answers because COVID-19 is such a dynamic disease that every day new things are being discovered. So what I'm talking today may actually be obsolete or incorrect by next week. And that is why the most important disclaimer that I want to give here is that it is just an assessment of the situation and a prediction of what is going to happen in future, but things may change. And therefore, this presentation of mine is divided into two portions. The first portion is to do with occurrence of a third wave, and the second portion is to do with how this third wave, if it were to occur, will affect children. So let us look at the past to know about the future. And we need to look at the other flu pandemics which have happened in the past 100 years. We need to look at the other coronavirus outbreaks which happened due to SARS-CoV-1 in early 2000, and the MERS outbreaks which happened in 2013-14. And we also need to look at how the COVID-19 virus or the SARS-CoV-2 has behaved till date. And if you look at these things, we may be a little better informed, and we may make better predictions about the future. So I will start with the Spanish flu or the flu pandemic of 1918, almost 100 years ago. And clearly, after this pandemic, the COVID pandemic has been the worst in the past century. And this was actually due to an influenza virus, the H1N1 virus, and it started in the US, but wrongly termed as the Spanish flu, because at the time of the World War One, basically there was censorship of the media in various countries. But the Spanish media was not censored because Spain was neutral to World War One, and most of the descriptions of this influenza epidemic happened in Spain, and therefore it was wrongly termed as the Spanish flu. And we know that it started spread with troop movements of World War One, and it spread over 2 years from 1918 to 1920, and it affected 500 million people and caused 50 million deaths. To just put it into perspective, we know that the current COVID-19 pandemic has affected 176 million people and has caused about 4 million deaths. So, looking at the Spanish flu or the 1918 flu pandemic, the COVID-19 is less severe. And actually, this caused about 10 to 20 million deaths in India alone. And if you look at the way the 1918 flu pandemic behaved, it had three big and one small wave, and it extended from early 1918 to early 1920. And the second wave was the most devastating because it happened due to a mutation in the virus. And this is just a graph from the US data, which showed that in US, where there were three waves, you had a small first wave, and then you had a massive second wave, and then you had a small third wave again, before finally the virus actually lost its steam. And then since then we had influenza as a kind of virus which remained with us, intermittently caused pandemics, and then comes every year and causes a substantial morbidity and mortality. So in a lot of ways, this COVID-19 pandemic is being compared to the flu pandemic. Of course, there are several differences, but this is strikingly similar to what happened in India and many other countries, where you had a very massive second wave as compared to the small first wave. Now, if you look at the other pandemics, we had the Asian flu in 1957. We started from China. It had two waves, caused an estimated 1 to 4 million deaths. Then we had the Hong Kong flu, which also lasted for 2 years. It was less severe than the previous pandemics. Then we had the 2009-2010 H1N1 pandemic, which also had two waves. And then we had these COVID pandemics, the SARS and MERS, which really had one wave, and they were stamped out pretty fast. And, they didn't cause so many deaths. They caused deaths which were just in a few thousands. And luckily, we didn't see them. And actually, when, this COVID-19 pandemic also began, people thought that it will behave like the SARS and MERS outbreak, and it is not going to cause so much of devastation. But obviously, we were proved wrong. So that we must therefore remember that, just making predictions based on the past may not always be accurate. So, what are the takeaway points from the past? The takeaway points are that most pandemics in history have lasted for 2 years, and they have had two or more waves. And if you if you connect them to the current scenario, then we know that we are already almost 1.5 years down the pandemic, and maybe we have another 6 months to a year to go. I mean, that is thinking that this virus will behave like what the other predecessor virus have behaved. Now, I just want to then talk about the waves of COVID-19 all across the world, because, this has been seen everywhere. So let us look at the global data first. And if you look at the global data, you can see that there are several waves in this data. You have a small wave here, then you have a larger wave, then you have a yet larger wave in terms of the number of people affected per day, and then you have another peak here. So the global data is basically, due to different countries contributing cases at different times, because this small wave here was actually because of this Europe and the US. and then you had this wave which was primarily because of India, Brazil, etc. And then you had the third wave, which was again due to Europe and US, and then you have this fourth wave, which was in which India played a major part. And if you look at the US graph, you find that basically you can see three waves in the US. You have a small first wave, then you have a second wave, then you have a third very devastating wave, and then you have a fourth wave. So again, the reason USA had this kind of distribution is because it didn't really do a lot of restrictions, etc., and that is why you saw this pattern. But now the sustained decline may be related to widespread vaccination. If you look at UK, again this had a small first wave, and then it had a massive second wave, which was actually 2A and 2B, which is again because of the new variant which came. And now it is being said that UK is on the threshold of a third wave. And in fact, many people who are predicting the third wave in India are also talking on the basis of the UK experience, that they had now the Delta variant. This wave was driven by the Alpha variant, but now the Delta variant has come in, and therefore you have had an increase in cases from 2,500 to about 10,000 per day over the past 2 weeks. And whether this is going to increase further, of course, the number of hospitalizations and deaths haven't happened. And if you look at Brazil, it is almost a little different, where you can see actually really no clear wave pattern, but you see, a steady number of cases happening throughout. And probably the reason in Brazil is that they didn't really do any kind of restrictions, and also they are very slow as far as vaccination is concerned. So, what is the summary of global epidemiology? It has differed across the world. There have been 1 to 4 waves, and some countries like China and Australia have had only one wave. I mean, we are all surprised that how China, where the virus originated, has just 90,000 cases, and it is number 96 on the list. USA has seen 3 to 4 waves. Europe has seen 2 waves, and UK may be on brink of a third wave. And Brazil has seen cases. And all these variations in global epidemiology have happened because of various restrictions, emergence of variants, and vaccination. These are the factors which have determined the occurrence of the waves. And we need to understand a little bit about the variants before we go ahead and discuss the third wave and how it is going to affect children. And this is just a quick refresher on that. So we all know now that the variants have been actually named more simply by the WHO as alpha, beta, gamma, and delta. The alpha variant first was detected in United Kingdom in September, and of course there was a variant which came in December. And this variant was different because it was more highly transmissible than the original Chinese virus. And however, it also there is also some data that this variant was more severe as compared to the other earlier virus, and also that it was not very well covered by the vaccine. So while the COVID, it was to a certain extent well covered by the vaccine. So the Covishield, Pfizer, and Moderna vaccines worked well against the alpha variant. Then you have the beta variant, which was first detected in South Africa. And basically, it was again detected around the same time as the alpha variant, and it was more highly transmissible. And one important characteristic of the beta variant, which was different from the alpha variant, was that it could cause infection in previously infected people. So many people in South Africa who were affected in the second wave had actually been infected in the first wave. So that means it was able to cause reinfections. And the other important thing about the beta variant was that some of the vaccines were not effective against it. Like, for example, the Covishield vaccine was not effective against the beta variant. Then coming to the gamma, which was first detected in Brazil. Also, it had some mutations which were quite similar to the beta variant, and it was detected in December 2020. And we know that it was also more transmissible, and it was able to cause reinfections and was able to cause more severe disease. And now we have the Delta variant, which is from India. And if you look at the Delta variant, you know that it is a little different from the previous variants, because you don't see these, common mutations in the other variants in this. And it is very, very highly, transmissible. So we have something which is called as a basic case reproduction rate. Whereas We know that for the original virus which originated in China, the basic case reproduction rate, that is the number of people infected by one person, was somewhere between 2 to 3. But we know that for the Delta variant, it may be 4 to 6. And that is one of the reasons why it caused such a sudden surge of cases in India. And however, as far as the Delta variant is concerned, while it does escape, the vaccines are not as effective against the Delta variant, but we know that it doesn't really cause a lot of reinfections, because we know that in India, most of the cases which happened in the second wave were in people who were not infected in the first wave. So that means all these variants have different properties, as far as they are all similar in the fact that they are more transmissible. But as far as protection offered by the vaccine is concerned and the possibility of reinfection is concerned, they are different. And now there is talk about this, Delta Plus, and the Delta Plus is basically a variant in which the Delta has acquired a new mutation, which is the K417N, and that is the Delta Plus variant. So basically, now with this understanding so far, and what is that we've understood so far, that most of the pandemics in history have happened in waves. And we also know that COVID-19 in other countries has also had a wave like distribution, and so also in India. So we have to now talk about the third wave. So when will the third wave hit India and how severe it will be? So there was a survey which was done of 40 people across the world who said it's October. I don't know how valid this is. As you heard, Dr. Randeep Guleria said 6 to 8 weeks. Maharashtra Task Force says, sorry, 1 to 2 or 2 to 4 weeks. But all people agree that this wave is going to be less severe and it will be better controlled. So that is what is being talked about, the third wave. So we need to really understand that what is the situation in India and what is the likelihood of a third wave occurring, and what will be its severity and what is going to happen to children there. So let us analyze it a bit better, and we look at the first wave in India. Now, if you look at the first wave in India, it was actually a very, very broad shaped curve, a bell shaped curve, which was very broad. And this wave actually extended for 10 months, from March till December 2020. There were about 10 million cases overall, with 1 million cases per month. It's important to know these figures because we'll compare it with the second wave. There were about 35,000 cases per day. And one of the reasons why this curve is so broad is because different parts of the country were affected in different times. So, for example, in the beginning, it was mainly Maharashtra which was infected. Then came the of the southern states like Karnataka and Tamil Nadu. Then it went to Delhi, etc., etc. So that means that is the reason why you have such a broad curve, because while the number of cases happened in one city at a alarming pace, but it gradually spread through the whole country, and that is how you have such a broad curve. But when the first wave ended, they said that there were 10 million actually reported cases. But that doesn't reflect the total number of people infected, as many infected people were asymptomatic, or they were not tested or tested negative. So that is why it is important to look at the data from the seroprevalence surveys. And the first sero survey was done in May to June, which showed that less than 1% of all adults more than 18 years were actually seropositive for the COVID-19 virus. The second national survey was done in August to September, which is just during the peak period of the second wave, and it looked at people above the age of 10 years, and they found that 6.6% of the population was positive, and this there was a variation in this positivity. So urban slums had the higher percentage positivity, urban non-slums had lower, and rural areas had only 5% seropositivity. And also, this survey showed that 1 out of 30 infections were reported, because therefore, based on the number of infections which were reported, that means for every one case that was reported, 30 cases were missed. Also, at that time in Mumbai in June and July, there was a sero survey which showed that 50% was the sero positivity in slums and 16% is in housing societies. So that also tells you that during the first wave, the different cities and different states were affected at different times. And therefore, in Mumbai, the sero prevalence was very high. Now, the third survey was done in after the first wave in December to January 2021 in people aged more than 10 years, and they used a better test than the second survey. And what this survey found was that the overall prevalence in people above the age of 18 was 21%, and actually between the ages of 10 to 17 was 25%. And also these people found that there was a difference because there was more infection in the slums, lesser in urban non-slum areas, and lowest in rural areas. Again, as per this survey also, it was estimated that 1 in 30 infections have been detected. So that is where we were as far as sero surveys are concerned. So why did the second wave happen? So why did the second wave happen? Because there was a large percentage of susceptible population. So that means that we had calculated that 20 to 30% of the patients, people were already infected by the time the first wave subsided. That means you had 60 to 70% of the population which was still susceptible. There was overcrowding. So people thought that we had achieved herd immunity because for almost 3 or 4 months, from the month of October till the month of February, cases were low, whereas the other countries were having cases. So they thought that maybe there is something unique in the Indians. That is why they are not getting COVID. Maybe we have herd immunity. Maybe we have better immunity because of all the hygiene problems. And you at that time, so people started traveling, people started having parties, and you had religious gatherings, and you've all read in the newspapers that how so many tests which were done during the Kumbh Mela were actually fake tests, and they were political rallies. At the same time, there was a poor vaccination drive because while vaccines had been licensed in January, the vaccination was so slow that in from 16 Jan till March 1st, there were only frontline workers were vaccinated. And also there was vaccine hesitancy in the population because most people believed that everybody has already achieved herd immunity, so why should we vaccinate ourselves? And they basically thought that the vaccines have side effects. So we know that there were several doctors who were actually hesitant to take the vaccine also at that time. And apart from that, there was emergence of variants. You had the alpha and the delta variant which emerged. This delta variant had very high infectiousness, and it was not detected in time by the body which had been set up by the Indian government to detect variants, which said that 5% of the samples have to be sequenced, and the same didn't happen. Otherwise, there could have been a warning that this highly infectious variant is there and we have to be careful, and we have to again start restrictions. And then once it took off, there was no stopping of the second wave. So these were the reasons why the second wave happened, and it is important to understand these reasons because we'll come back to these reasons when we are talking about the third wave. And this is the second wave. So you can see that the second wave is very different from the first wave because it is, it has a very sharp peak and a more larger peak and then a sharp decline. So these are the differences between the first and second wave. The first wave was started here and peaked after 6 months, whereas the second wave peaked after 2 months itself. The total cases in the first wave were 10 million over 10 months, whereas in the second wave, they were 18 million in a period of just 3 months. Peak cases were 4 times more. Average cases per day were almost 5 to 6 times more. The surge speed and volume was 5x the number of cases, and it was driven by the variants. And important to understand that in the second wave, reinfections were uncommon. And in fact, they were even lower than vaccine induced breakthroughs. That means if somebody has got natural immunity to the COVID-19 virus, they are better protected as compared to people who have received the vaccine. Now, the following will determine the severity and timing of the third wave. So as I said, it will be based on the current pool of susceptible population. It will also depend on the vaccination coverage and protection offered by the vaccine against the new variants. It will also depend on the crowding factor, and it will also depend on whether a new variant emerges, which is more infectious and which can break previous infection or vaccine induced immunity. Because if you have people who were infected 1 year ago and now after 1 year the immunity is declining, then they become susceptible again and they can be reinfected. So all these factors will determine the severity and timing of the third wave. So if you look at the susceptible population, now we know that so far about 30 million people have been infected in India. And we know that 1 in 30 people is detected by the test, because both the first sero survey and the second sero survey found that for every one case which is reported, there are 30 others which have not been picked up. So we can then hypothesize that there are about 900 million people who have been infected so far. And that means about 70% of the population has been infected. This is a rough estimate. And remember that it is not uniform around the country. So there may be areas like in metropolises where you may have 90% of the population which has been infected, and you may have other areas where 20% of the population may be infected. So we have another national seroprevalence survey, which is the fourth survey, which is still ongoing, but we have data about from 4,500 people from 4 states, and these are all rural areas of National Capital Region, Bhubaneswar, Gorakhpur, and Agartala, where children 2 to 17 years and adults were tested. And what these surveys found, that the seroprevalence in children was 55% and that of adults was 63%. So this seroprevalence estimate is in line with what is predicted based on the number of cases which have been reported. And if we assume that 60 to 70% of our population has already been infected, it means that we have actually reached the threshold of herd immunity. Then we have to look at what is the vaccination status, because we know that vaccination had a great had an important role to play in cutting down or in stopping the second and third waves in Europe and USA respectively. And if you look at the situation of India, we know that in India only 15 to 16% of the population has been vaccinated, and 3.5% have received 2 doses. So that means we have a long way ahead. And we must understand that many of these people, 15% who have been vaccinated, may include people who are already infected. So that means you have a cohort of people who are either not naturally infected and who have not taken the vaccine. The other thing is not just the coverage of the vaccines, but what is the protection offered by current vaccines available in India against the various variants, and especially the Delta variant. Now, if you look at Covaxin, it gives 80% protection against symptomatic infection in clinical trials, but there's really no real life data. And we also don't have any data about how effective it is in protection against the Delta variant. Of course, there is some lab data which is available. As far as Sputnik is concerned, which has just made the entry and vaccination with Sputnik has just started, we know that 90% protection in trials, but we really have no real life data about how it has actually performed in Russia or other countries where it is being widely used. On the other hand, for Covishield, we know that Covishield or the AstraZeneca vaccine, as per the clinical trials, gave 60% protection with dose interval of 4 weeks and 80% with dose interval of 8 to 12 weeks. But now with Covishield, because it was widely used in many countries, especially the UK, you have real world data also from UK with a single dose. And this was between December to April 2020, and it showed that it was very effective, even a single dose, in reducing mortality, reducing hospitalization and symptomatic infection, and cutting down transmission. So even a single dose was effective, and that was one of the reasons. So why did UK start with this strategy of 2 doses between 8 to 12 weeks? Because the trials showed better efficacy, and they wanted to vaccinate a large percentage of their population first before they gave the second dose. And other data is from South Korea also, where it showed good efficacy of single dose of the Covishield. But the question is, what protection does Covishield offer against the Delta variant, which is the one which is circulating in India at this time? So there is some publication in this respect which showed that the protection against infection with 1 dose was 33% and 2 doses was 59%. However, when you're looking at protection against hospitalizations, 1 dose gave 71% protection and 2 doses gave 92% protection. So that means 1 dose of Covishield against the Delta variant was fair enough, because it did give 70% protection against hospitalization. But if you look at the Pfizer vaccine, you know that it's better against the Delta variant as compared to Covishield, because that protection rate was 92 and 96% respectively with 1 and 2 doses. So that means Covishield does give protection against the Delta variant. And there is also data about Covishield protection in Indian setting, because this is data from CMC Vellore in its 10,000 odd healthcare workers, of which 85% were vaccinated between January to March 2021. And they looked at the protection offered by this vaccine, because most of the people received Covishield during the second wave, and they found that one dose was giving protection against infection as 61%, 70% against hospitalization, and 95% against ICU care, whereas it was slightly better with two doses. And you must see that the confidence intervals are narrower when you look at two dose protection. So that means, and this was the time where we know that there was the Delta variant also circulating all over the country. And therefore, we know that the Covishield also gives good protection. So that means that, and that is one of the reasons that Covishield 2 doses at 12 to 16 weeks is okay. And there's a article by Dr. Chandrakant Laharia, a renowned epidemiologist in today's Times of India, where he says that you must protect as many possible with one dose to reduce hospitalizations and deaths. And then you should give the second dose, because there's a lot of talk that whether we should now go back to the 8 week or 6 to 8 week interval. So that is the current thing about the thing. So that means what we know is that if we are going to vaccinate at the rate of 3 million vaccines that we are giving currently, by the time we 2 or 3 months pass by, 20 to 25% of our population is going to get vaccinated, and at least we know that these vaccines give some protection against the Delta variant. So so what will happen now? So that means I want to tell you that we have a larger percentage of population which is susceptible, which is less, which is infected and already immune, and we have better vaccination happening. So what will happen is that, one is because there may be a slower decline in cases or a wave 2B. That means because after the lockdown and the relaxations have been given up, you may actually see again maybe 60, 70, 80, or 100,000 cases happening per day. So you will see a slower decline in cases. And but after this, the chances of a severe third wave appears unlikely. And why is that so? Because a large percentage of our population has also already got immune, and our vaccinations will pick up, unless we have a highly infectious variant which will come into the picture that will escape previous infection and vaccine induced immunity. So unless this kind of variant emerges, which is not entirely unlikely, because we know that this virus is behaving in the strangest possible way till now, and that may happen. But if you look at the trend, then you know that the third wave is going to be less severe, and it will affect less people. So moving from that, so as I said that there are two parts to my presentation. One part is about the third wave. So we have discussed till now that yes, there will be waves. India will see a third wave, but the likelihood is more that this third wave is going to be a milder one as compared to the second wave. Now, if we look at children, the story so far about children and COVID is that children are less likely to get infected. And that is because some of it is that they are more resistant to infection, and some of it is also because they are less likely to get tested, because once a child is sick in the family and there are multiple adults who are positive, the child may not get tested. Also, we know that less likely to get hospitalized and die, and the fatality rates of COVID in children are 20 or 30 times less as compared to adults. And why does this happen? This happens because the ACE2 receptors are immature, they have better immunity, they have fewer comorbidities and healthier lungs. And what is a greater concern to pediatricians is the problem of MISC. But it also is a rare phenomena, and if these patients are treated, they have good outcomes. Now, and if you look at this data from the UNICEF, you can see that these are the distribution of cases by 5-year age groups across the world. And you can see from this graph that children and adolescents contributed to 13% of the total number of cases of COVID-19. This was done way back, so that's why the total number is 88 million. But now we have 176 million cases, so it was probably halfway through the pandemic. But again, you can see that the number of children who are infected are just 12 to 13%. And if you look at the percentage of deaths in children, then you can see that only very few children have died from COVID-19, which is actually 0.3% of the total number of COVID deaths. So while the children contribute 25% of the world population, their chances of them getting infected with COVID is just 12 to 13%, and the chances of or their contribution towards the total number of cases is just 12 to 13%, and their contribution towards death is just 0.3%. And but we all know that the indirect effects of COVID in children have been far worse than the direct effects, because they have been orphaned, especially after the second wave. We know that children have been, they have lost either one parent or both parents. There is a learning crisis, especially in children of lower socioeconomic status who don't have access to remote learning. There are mental health issues, obesity, excess screen time. Many families have been pushed into poverty because of COVID, and that has had its effects on children. Children have been abused because parents are out of job, their parents are at home, or the parents are going through stress. Immunizations have been missed, and there has been inattention to other diseases which affect children. And also to the fact, so these have all been the indirect effects of COVID on children, which are far worse than the direct effects. So far, children have been directly less affected. But what about children and the third wave? So this is what actually sent the whole country in a tizzy, because about 6 weeks ago we had this statement which said that third wave of children COVID will hit children in a big way. And what stoked this statement? So why was this statement made? So one of the reason was the first wave, that was the general impression among people, is that the first wave affected the elderly and adults with comorbidities, whereas in the second wave you actually saw a lot of young adults between the ages of 18 to 40 or 50 also getting severe disease and dying. And therefore, as a as a natural extension of this phenomena, you will see children by the time the third wave comes. Also, Brazil is reporting higher deaths in children below 5 years of age, mainly because of the P1 variant, or which is the Gamma variant from Brazil, which they thought preferentially affects children. Also, people thought that children have been relatively less infected as compared to adults because they have been at home all this while, and therefore when they go out, they will be the ones who will get infected, whereas the adults have already got infected and they'll be immune. And finally, because currently all the vaccines are being given to adults and elderly, children won't be vaccinated, and therefore they will be more susceptible to the third wave. But let us look at affection of children during the first and second wave in India. And this is just a publication or a tweet from the Ministry of Health and Family Welfare, which has looked at the age bifurcation of cases in the first and second wave. So if you look at the distribution in the first wave, you can see that actually both the graphs are very, very similar in terms of the age distribution of cases. And you can see that the age distribution of cases between the ages of 1 to 20 years has been the same in both the waves, and it is just about 12% of the entire population. Now, whereas we know that children contribute to 40% of the population in India. However, we don't have about data about age bifurcation of deaths due to COVID-19. Now, the other, so basically, so we cannot say that in the second wave, children have been worse affected as compared to the more affected than the first wave. The affection of children in the second and first wave was the same, but the absolute numbers were more because in the second wave you had 4 times more number of people. Now, the other thing which stoked that statement was that children are more susceptible as they haven't been naturally infected, because only 12 to 13% of all cases are in children, whereas children contribute to 40% of the population. But the National Sero Survey data does not say so. And again, I'm going to refer to the National Sero Survey data. So this is the first Sero Survey I talked about in between August to September 2020, where you didn't have information about less than 10 years, but between 10 to 17 years, the seroprevalence was 5.4%, whereas it was ranging from 6.2 to 6.9% above 18 years, and with an overall rate of 6.6%. If you look at the Sero survey, which was done between December to January after the end of the first wave, you actually find that the percentage prevalence in 10 to 17 years is higher than in those above 18 years. And then when you look at the Sero survey, which was done in March, between March to June 2021, you find that below 10 years, 42% were positive for antibodies. Between 10 to 17 years, 55% were positive, and above 18 years, 63% were positive. So that means while children have not been reported as cases of COVID-19, they are already infected because they have just not been tested, because either they have had asymptomatic disease or they have had very mild infection. So it is not true to assume, it is not correct to assume that in the third wave they are more likely to get infected than adults because they don't have natural immunity. The third question is there in your mind is that will children have more severe disease in the third wave due to change of the virus? So, okay, we are saying that children will not get preferentially more affected, but what if they get more severe disease? Because you have a variant or a mutant virus which comes along which is able to kill children. And if you look at, especially this was because of this news from Brazil that children that the P1 variant or the gamma variant was causing problem. But then when they looked at this thing, they felt that it may not be due to the actual increase in severity of the disease, but because children were at lower um, uh, you know um, uh, priority, they were not tested early enough, and the health infrastructure was poor. So that may have been the reason why more children died in Brazil, unlike instead of it being a virus which preferentially affected them. And actually, you have something to corroborate this even from India. So what they did was that they looked at 2,600 children less than 10 years hospitalized in 10 hospitals all across the country, and they found that mortality in these hospitalized children was 2.4%. And what they found was that when they looked at the data of the first wave and the second wave, they found that the hospitalization rates or the death rates were the same in the first and second wave. So that means that while the second wave happened because of a different virus, the Delta variant, it was still not affecting children in a worse way as compared to the original virus. So that means it is now very, very clear. I think there have been so many headlines over the past 2 to 3 days which are clearly saying that, look, this is all a very crude statement, it's a loose statement, and by every criteria, children are not going to be preferentially affected in the third wave. So we don't need to worry excess about them. Of course, we have to be careful. Also, another important thing is, what was being said is that you need to include children in vaccination. Child vaccine should come because parents feel very worried that they are getting vaccinated, but the children are not getting vaccinated. Whereas usually it's the other way around. Children get the vaccines first as compared to adults. But we must understand that the priority of vaccination is more in adults than in children. While it is a very emotional issue, but even the WHO has said that first the country should vaccinate its adults and elderly, and then only think about vaccinating children. In fact, it has gone ahead to say that developed countries should not vaccinate their children, but they should donate the vaccines to other countries where the adults and elderly can be vaccinated. So remember that we don't have to be unusually worried about children in the third wave, and we don't have to try and really and it is okay to allow them to go to school, etc., without being vaccinated. So I think I would like to end my presentation. First, saying that the current discussion of the third wave is premature, as the second wave is not over yet. And we still don't know whether we might see a wave 2B like USA and UK have seen because of the opening of the lockdown, etc. The predictions for a third wave are more out of caution than science, because we don't want to be caught napping, because nobody wants to say that no, we won't have a third wave, because it will induce complacency. Because what happened after the first wave is everybody became complacent, the government became complacent, the people became complacent, and that responsibility for the second wave is not just with the government, it is also with the people who didn't follow COVID appropriate behavior. We also know that third wave should be less severe because we have a large pool of immune adults, our vaccinations will pick up. So we know that whenever the third wave happens, it will be less severe and it will not preferentially affect kids. But an unusual variant may change the time. So, now there is all this talk about this virus may be a genetically engineered virus, and therefore it may not follow the rules which naturally evolved viruses do. So, if something like that happens, then maybe we'll again see a very severe third wave, etc. But despite all this, despite the fact that a large percentage of our population has become immune, despite the fact that vaccination will catch up, despite the fact that children are still going to be better protected, we should follow COVID appropriate behavior. That is very important for us as individuals to continue to wear masks, continue to follow social distancing, continue to not organize parties and gatherings. And the government should strengthen health infrastructure, because no matter, even if a third wave doesn't come, pandemics will continue to come, and therefore we need to be better prepared. We don't want the same situation as the second wave, where we were not prepared and we had made headlines all over the world because of lack of oxygen and hospital beds. At the same time, we have to do extensive genomic surveillance, so that if there is a new variant which has emerged, we are able to pick it up and we are able to extend restrictions, etc. And finally, vaccinate at a furious pace. I mean, from 3 million a day, we need to reach at 10 million a day, so that, for this time which we are getting between the second and maybe the third wave, we vaccinate the population. I think with that, I want to end my presentation and take questions.
Thank you so much, Dr. Tanuj. And I know we have been discussing so many things about COVID, but there's always, like, the bottom line of it, that there's always some myths, some confusions. We are not sure which data to believe and whatnot. And when it comes to children, it of course becomes very, very important, because it's itself, pediatric care is itself a very sensitive topic. And thank you for putting light on so many things. The last slide where you talked about that it is of course a preventive measure, and we have to still be prepared. So I would really take this moment to thank you from the entire team of Docplexus and our audiences out there. And it was a great presentation. Thank you, Dr. Tanu. And we have some questions from the audience. So if you are ready, I would just read them out for you. Yeah, so
Yes.
our first question is from Dr. Mamta Patil. So her question is that what are the specific reason of targeting children, and how best children can be taken care by their parents?
So, as I said, that the virus will not target children specifically, the reasons I've said, but still children have to be protected. And I think the best way to protect them is if adults protect themselves, because most children are affected by adults. So, if the adults follow COVID appropriate behavior and the adults take their vaccination, then they will protect the children at home. And we know that when schools reopen, the schools will take precautions, so that they will also take sure that overcrowding and all doesn't happen. And children above the age of 5 years should be encouraged to wear masks properly. So you have to teach your children how they should wear masks and how they can go out in the open but not in closed spaces. So those would be the correct things. Another thing which I would tell parents is that they should immunize their children with the routine vaccines. They should make sure that their vaccination is up to date. Children below 5 years need to take their flu vaccines, and they should take care of the nutrition of the children and mental health of their children, which may have been more affected than the physical health.
Thank you so much. And moving on to the second question, Doctor. This question is by Dr. Prakash Jain, and the question is why pediatric age groups are considered more vulnerable in the third phase.
So I have already answered that in my presentation, that it is
Correct.
not going to be more vulnerable. They will be this. They will have the same vulnerability as adults. So they will not be more vulnerable. I have already said that children, they have been, their natural infection rates are same as that of adults. And also data shows that in the second wave, children were not more affected than the first wave, and the severity of disease was the same as the first wave. And it is unlikely that the virus will change its nature so much that it will affect children in a severe manner.
Correct. And that brings me to the last question, which is by Dr. Bhimaya. What do you mean by a wave? How do you recognize a wave, and how do they differ from a pandemic phases?
So, I mean, wave is the term used for the distribution of cases over time. And you can see that there is a rise and a fall, like what we see in a wave. And it is also, in a way, something related to the phases of a pandemic. But the term phase is mainly used for the global distribution, whereas waves are something which you see in the individual regions. You know, so the pandemic may pass through different phases all over the world, but individual places you see it as waves in the wave form because the epidemiology differs in different countries.
Correct. Thank you. With that, doctor, another question just came up, and the question is that please discuss symptomology and management if it is at all different from adults for children.
So, children, as I said, the chances are higher that they may remain asymptomatic after infection, 50% maybe that rate. And even if they have symptoms, they are much milder than adults. So, they have fever, which may last for just 2 or 3 days. They may have a little bit of stuffiness and cold. We don't see that same amount of exhaustion and fatigue as adults see with COVID. And the illness gets better very quickly, and most children do not progress into that phase of pneumonia, etc. And also, as far as management is concerned, because children have very mild disease, the you only give symptomatic care to children. You just give them paracetamol, etc. As far as management of very ill children is concerned in the hospital, it is more or less the same as you manage adults. One salient difference between children and adults as far as the symptomatology of COVID is concerned is the multi-system inflammatory syndrome. That is a phenomena which is more commonly seen in children as compared to adults, in which children, after getting mild COVID infection or acute COVID infection, after 1 month, start having high fever and other complications. So that is something which is unique to children. Otherwise, I would say the disease is much milder in children.
Much and more or less the same. Okay. Thank you. I think that answers all of our questions, and thanking you again for patiently answering all the questions, Doctor. We look forward to hear from you again. And to all my lovely audience out there, thank you all for taking out the time and coming and joining the session. As you know that we have been telling that the only way we can combat the pandemic is by coming together, and being driven by accurate information and knowledge, and that is what Docplexus always attempts to bring to you all. And stay safe, all of you. Please stay connected. Happy Docplexing, and I'll see you all soon. Thank you, Dr. Tanu. Thank you so much.